Hey everyone, and welcome to the Hormone Genius podcast. Today, I get to ask Teresa all about endometriosis. So these are my favorite episodes of all time. I love to learn, and Teresa teaches me so much. And endometriosis is something, from even my perspective as a fertility care practitioner, that I work with couples on, and I see charting patterns for. But what's so beautiful about what Teresa does is she takes the data from charts to help women really understand and kind of get to the root and kind of target some of those lab works and diagnostic testings based on what she sees in charting. So we're going to talk about the basics of endometriosis. We're going to talk about what endometriosis is. We're going to talk about what do we do physically, like how do we manage that? How can doctors like Teresa, medical professionals like Teresa, assist us in that way? And I'm just really excited to get started.
Yes, I'm excited too, Jamie. This is obviously a super important episode. I think there's a lot of women out there who have endometriosis and know it, but I think there's a lot of women out there today that are going to be wondering and have been wondering for years if this is a possible diagnosis for them, but they don't know how to get the right answers and they don't know who to go to for those answers. So this is going to be hopefully a first step for a lot of you to say, okay, this sounds like me. Let me take the next step to improve my health or to get this diagnosis.
Totally. Okay, so for those of you wondering what endometriosis even is, let's start there. Teresa, what is endometriosis?
Yeah, so endometriosis is a chronic condition. It's a disease where tissue forms outside of the uterus. And the tissue that forms outside of the uterus, so of course, the uterus is inside the pelvic area, part of our reproductive organs, is endometrial like. So we're talking about, so a lot of times you'll hear people say, oh, it's the exact endometrial tissue, it's just gotten in the wrong place. And I've gotten a better understanding of this. It's not just endometrial tissue. It is different endometrial tissue. It's endometriosis like or endometrial tissue like, but not exactly the same. So that's just important to know. It's little inflammatory, you could say tumors, you might call them vesicles, you might call them lesions, but they are little places where this particular tissue, endometrial like tissue, has formed in places in the pelvic area and outside the pelvic area. And they create an inflammatory condition, and they're very responsive to hormones, particularly estrogen. So women who have this condition end up having a lot of chronic pain due to the fact that these lesions create a lot of inflammation in their body.
I did not know that it was endometrial like. I did just assume it's like that same tissue that just grows in other parts of the body. So for our listeners, just knowing kind of where this tissue can grow, will you kind of explain some common places in the physical body outside the inside of the uterus that these lesions can be found?
Yeah, so we find endometrial or endometriosis tissue in all sorts of places in the pelvis. Most commonly, they're found on the back of the uterus or what we call the rectal vaginal area. They're also on the front of the uterus, along the lining of the bladder and on the bladder. They can be on the fallopian tubes, they can be on the ovaries, they can be on the pelvic walls. Endometriosis can form on the bowels. It can actually form on the rectum. It can form on the diaphragm. It can form even in the lungs, less commonly. And in very, very rare cases, it's been found in the brain. So the most common places is right, kind of, you could say, to the confines of the pelvis and around the basic reproductive organs. But there are a lot of women who actually develop it in places near that, and especially in the bowel related areas.
Interesting. So, for women listening again, and even for men listening, you may be wondering, okay, so how does this apply to potentially what my loved ones or I personally experience? So, what would be like the first clue, Teresa, that
Mhm.
someone might have endometriosis or should just look into it further?
Sure. So I'll just because stories are always good, like a common story that would come to me that where we would kind of make this decision. Okay, could this person have endometriosis? And I give two examples because they're probably the most common examples we see. One would be an adolescent or someone in their teens to early 20s who presents with very painful periods. And oftentimes, if they've seen me and they've gotten to their 20s, this is a condition that's probably developed over years. So it's, of course, influenced by hormones. So most of the time, it doesn't start until you've started your menstrual cycles. And when a girl comes to me, let's say at the age of 20, 21, and she's been experiencing painful periods, what she doesn't seem to recognize is that maybe this isn't quite normal. We tend to, as women, kind of be like, well, I bet everybody's got painful periods like this. Or I'm just not sure. Like, I'm almost afraid to talk about it because, I mean, this really affects me, but doesn't seem to affect other people the same way that it affects me. Those women with this type of painful periods, it's not like just your typical cramps. I mean, we're talking cramps that put you home for a day of school, cramps that don't allow you to go to work, cramps that are forcing you to take a lot of over-the-counter analgesics, cramps that cause nausea, cramps that basically affect other parts of the body. That would mean that you get a lot of low back pain or you get bowel symptoms. So very commonly with endometriosis, we find women complain of rectal pain or pain with bowel movements. And this young girl, she's probably been to many doctors at this point. And if she wasn't already on birth control before she saw me, she certainly was offered birth control because the medical answer to endometriosis is suppression of your menstrual cycle, which may give temporary symptom relief, but is not an answer to endometriosis.
Mm-hmm.
So this is a very frustrating condition and also one that really affects the self-esteem of women because again, as a young woman, they're wondering if their body's normal or not normal. And then they've got this painful condition and they're told by many people, maybe it's just bad cramps and you just need to take more ibuprofen.
Mm-hmm.
So it can be very frustrating. And on average, endometriosis takes upwards of 10 years to get a proper diagnosis.
Mm.
So when I get a patient like this, who's younger, I certainly assess whether they've gotten proper medical therapy. And what I mean by that is medical therapy is not surgical. It's either some sort of a medication or a treatment that is helping the disease or trying to get to the heart or root of the disease. And many times that is proper use of medications like nonsteroidal anti-inflammatories, like ibuprofen.
Mm-hmm.
And there's other ones too. But if a young girl has never used ibuprofen correctly with their period, this may be an important step to start with because it can, for me, be the deciding factor on whether this could be endometriosis or not.
Mm.
And so we start with medical therapy. And if she fails medical therapy, and we don't wait too long for that. I mean, this is not about making women suffer for months and months and months. So if she fails my proper medical therapy, then what we need to ask is, does this affect the patient's quality of life significantly enough that she's, again, not functioning on certain days? Is the pain significant enough that she is taking a lot of pain medication to deal with it? And if those two things are true, we have to get to the underlying root cause. And that gets to, the next kind of step is what is the, diagnosis? How is the diagnosis of endometriosis made? So, Jamie, what have you heard about how endometriosis is actually diagnosed?
Well, I know for us, and when we're working with women, like laparoscopy, you have to look to see if that tissue is there. And something that I've learned as just being a fertility care practitioner within the Creighton method is that often when we think about treatment of endometriosis, we think about lasering the tissue, lasering it off. But really what I love, and we could talk about this more later, is that it's really effective when it's excised, when it's surgically removed. And as I was learning more about endometriosis, as I was starting to work with clients, I learned that the reason why surgeons don't recommend excision, most don't, is because of adhesions that form. But with surgeons that are trained through NAPRO technology, they actually do this in a different sort of way. something that I was thinking of, Teresa, as you were talking, is how this pain with our menstrual cycle, like you said something earlier on about how if women don't know, they just think that that just might be the way it is, that you have pain in your period during your period. But how many women experience this pain and think, well, this is just the curse of womanhood. So this is one curse of womanhood we're thinking to ourselves, okay? But honestly, this pain means that there may be this root issue, which is what we're talking about, endometriosis. Definitely go and see your physician and get that treatment and try to come up with some plan. But it doesn't have to be this cursed time, but if we don't know anything different, we don't even know that.
Right.
And so what I find just so fascinating, but also very frustrating, is that that the pill or these synthetic hormones are being prescribed to then shut down all of our reproductive organs, when really there's this serious matter that is going unaddressed. So anyway, you asked me, how do I see it presented? And as a fertility care practitioner, I see it in charts. And again, there's clues. There's clues when women are charting their cycle. And of course, as a fertility care practitioner, we don't diagnose or treat, the woman. We're just looking for these charting patterns. And so we can get more into that too. But yeah, it's just so fascinating what women don't know. And that's what we're here to kind of shed light on.
Yeah. Well, yeah. So let's go back, because I want to go back to the original question just a little bit, because this is important. A lot of women will say, I've been told I have endometriosis, but they've never had a laparoscopy. So let's just remember that the only true way to make the diagnosis of endometriosis, to be 100% for sure, is a surgical diagnosis. So you have to have a diagnostic laparoscopy, just like if you had a lot of colon problems and you had celiac disease or Crohn's, the diagnosis has to come through a colonoscopy or an endoscopy. So someone has to look, has to take a biopsy of that tissue and truly identify it as endometriosis. So if you've had an ultrasound and someone says, oh, you have endometriosis, likely, no, you can't really make the diagnosis with ultrasound. It'd be very, very, very unlikely to even see endometriosis on ultrasound. So remember that the true diagnosis is a surgical one. And then, so you brought up the charting, Jamie, and you brought up the word naprotechnology. We've talked about naprotechnology, and not all charting is going to, when we talk about signs in terms of identifying endometriosis, not all charting can do that, because this particular science, naprotechnology, did research on charting to try to identify what factors were linked to different things in women's health. Mm-hmm. And so it's the Creighton model system of fertility care that was developed as a foundation to naprotechnology. And it's that charting system, when Jamie is mentioning that she's a practitioner of that charting system, and that we can identify clues for endometriosis in that. Now, that might sound weird, because you're like, well, how do you know you have endometriosis by a chart? And it's not like, again, it's not something that like physically jumps out at you in a sense. We can't see anything in the body, but we can see a window into what's going on in the body through the charting. And that means that, what we found is that women who have endometriosis tend to have limited mucus. So that is something that was found through naprotechnology. Limited mucus. They tend to have hormonal dysfunction. So they're likely to have luteal phase dysfunction or other hormonal dysfunction. And then they also have pain, of course, that's associated with the endometriosis, but it tends to not just be during the period. And so women are more likely to identify and chart that. Like during ovulation, women have more pain with endometriosis, and during intercourse, many women would experience pain with the endometriosis as well. So women who chart, the self-awareness factor goes up by 100 times. And so we're able to kind of very quickly clue into these, little details that allow us to get to the heart or truth of the matter much, much quicker. And I know Jamie's probably seen that just in her own, being a teacher. Have you had any stories, I guess, that, where you kind of helped a woman through that path?
Yeah. Well, there's a couple stories. One, I'll start with kind of just the basic, typical client that you would imagine, again, with the painful periods and the limited mucus. And yeah, like noticing that the luteal phase is the phase after ovulation. So the follicle, which houses the egg, becomes the corpus luteum, and that's the luteal phase defect. So when we talk about a luteal phase deficiency, that's what that means, and it produces progesterone. And so if there's a luteal phase defect, it just means that there's less. So we can see that when we're doing lab work and things. So yeah, I do notice that, the limited mucus, but what I'm most surprised by are the women who have PCOS, but also not knowing that they also have endometriosis, and that their periods aren't super painful. But once they do surgery, it's possible, like, this couple is trying to achieve pregnancy for years and years. They're not understanding why. They might be on metformin or some ovulation inducing drug, and it just isn't working for them. So we refer them on for surgery, and then they find, lo and behold, not only PCOS, but that they also have endometriosis. So those are the ones that I'm so glad that they come to see us. I mean, I'm glad everyone comes to see us, but it's like we uncover and we're investigators to this. And those are the ones that are more surprising, are the ones that have endometriosis, but without that pain.
Mm-hmm. Yeah, it's a really good point to make. Yeah. So there are varying degrees of pain with endometriosis, and we have to look at all of the symptoms, not just pain with periods, but all of the different types of discomforts that occur with it. But we also have to remember that infertility itself is a symptom of endometriosis. And, this is something I see on a daily basis in my job. And I think it's the most disheartening part of the diagnosis of endometriosis, and the fact that it takes so long to get an accurate diagnosis because of its impact on fertility. Mm-hmm. So we know that at least 60% of women who have infertility probably have endometriosis. The statistics out there are varying. In fact, I was just on the CDC, and I was looking at our and where I am in Omaha, Nebraska, our two biggest infertility clinics that are artificial reproductive technology clinics, and what they put as their percentage of diagnosis of endometriosis. You can do this at any IVF clinic around the country, because I'm always interested, because I feel like IVF oftentimes misses this diagnosis, this so important diagnosis. And you can see it in our two largest IVF clinics in Omaha. The percentage of women that they diagnosed with endometriosis in the largest clinic was only 10%. And the one that was in the smaller clinic was 17%. So, but in our clinic, we see 60, probably more percent of our patients that have infertility have endometriosis. And it oftentimes is not, this super classic, I'm in pain all the time situation. And you can also have women, and this is an interesting story. We had twins years and years ago at my clinic, 15-year-old girls, and the mom had endometriosis. So if you didn't know this, that family history does count. There is a family or genetic predisposition to endometriosis. We had two 15-year-old twins whose mother had endometriosis, was treated at our clinic before, and now her daughters were experiencing incredibly painful periods. Well, one was experiencing incredibly painful periods. The other one presented more like PCOS. And inevitably, the one with super painful periods, we definitely needed to do a laparoscopy on. But because of the PCOS and the mild pain and the twin, she ended up with a laparoscopy later as well, very soon after. What was interesting was that the girl who had less pain had terrible endometriosis. I mean, it was a degree or two beyond what the other girl, who had tremendous pain with her periods, she had endometriosis, but it was milder. Wow. So you cannot, just because of the degree of pain does not always correlate with the degree of severity of disease. And that I found really fascinating, because they're twins. So they were identical twins. So they were genetically identical. So you just wonder what all the factors that go into that. And so that brings us, I guess, to the question of why do we get endometriosis? Yeah. Mm-hmm. And unfortunately, in 2021, we don't know. There are theories. They often refer to endometriosis as kind of like the biggest theoried disease, because there's so many theories out there. You could pick one of probably 10 to go with the disorder. And so we don't really know, but I think from my opinion, when I've read and looked at, is that it is probably genetic factors, environmental factors, epigenetic factors, and hereditary, well, genetic and hereditary. So, and autoimmune, that was the last one I was going to say. So autoimmune. So it's immune dysfunction, environmental and genetic and epigenetic factors that probably lead to endometriosis. And the retrograde menstruation, you'll hear about that. That has been debunked. So there are a lot of theories out there, but we really don't largely understand why it happens. There's even a theory that it starts when you're in your mother's womb, that it happens as a disorder of embryonic tissue. So a lot more to understand about this disease, and you can understand why we don't probably understand what we should, because we suppress women's cycles all the time to, deal with these. And the medical treatment for endometriosis is suppression, suppression, suppression. If it's not oral contraceptive pills, it's then the next step are these drugs that put you into a state of menopause called GnRH agonists, and they're miserable. You can read horror stories all over the internet about how terrible women feel on these medications. And so the treatment, the medical treatment is not effective. Why? Because it doesn't get to the disease. I'll often say to patients, now endometriosis is not cancer. It's not cancer at all. But I often say, if I was told as a patient that I had cancer, let's say I had cancer and they were tumors inside my body, and the doctor said to me, well, we can put you on this medication. It won't take your cancer away, but it'll buy you about 5 to 6 years, or however much a time and then we'll take you off of it, but you still have cancer.
Yeah.
I'd be like, I'm not sure that sounds like the best idea. What about like getting rid of the cancer?
Right.
And the only effective way to really truly get rid of the disease is to surgically remove it. Just like if you had cancerous tumors and you would, have a good surgeon that took those out to give you the best potential cure of your disease.
What you said earlier too, with how, we're suppressing our cycle. So, the research behind this disease is not nearly as advanced as it could be, truly, because we were talking about this in a earlier episode about, it's really this supply and demand. Like we have to demand that we get this care. But if again, we're covering up these symptoms and living life and almost assuming like, again, that this doesn't exist. And again, a lot of women, and I don't know how many women, Teresa, maybe like many women likely have endometriosis potentially, but they don't know it. And then they go to the doctor and then they put them on the pill. They still don't know it. They still don't know they have endometriosis. All they know is that they have really painful periods. So let's kind of dig into that one too. What percent, I mean, it's hard to know, but what percentage of women do you think, are really just covering this up when really it needs to be addressed? And what kind of repercussions might that have on their goals of achieving pregnancy later on?
Yeah. Well, I read a statistic that said that 70% of teens who have painful periods, very painful periods, will end up with a diagnosis of endometriosis. That's a lot. I'm not sure if that's accurate. I think there's a great source out there for endometriosis called the Center for Endometriosis Care that has a lot of great information on endometriosis. But that's a lot. So, but how long that teen or adolescent to older teen gets the diagnosis is just takes so long because of, again, these suppressive medications. So oftentimes I can picture myself at a pre-marriage class, because I teach those. And I will tell them about the charting and how empowering this information is for women's bodies, and how we can get to underlying diagnoses, even, and treat women's health issues by charting. And women who have been on the pill since they were 14 or 15 often come up to me afterwards. And they're like, well, I've been on the pill since I was 15 or 16 because of my really, really horrible periods. And they're like, I'm not sure if I should come off the pill. They have all these questions. But think about it. If they had endometriosis, they just wasted 10 to 15 years of time to get the right diagnosis. And potentially, like, this could prevent them from conceiving naturally in an easy way.
Mhm.
And we want them to have the best chance of that. So, is it good to suppress it for a long period of time and then just try to get pregnant? No, it's not. It doesn't help the condition. So, it's better to get the disease accurately diagnosed and to actually get real comfort or real cure or the best chance of cure.
Mhm.
So I want to go back to the surgery part of
Yeah.
it, Jamie, because this is so important. And you mentioned, yes, NAPR technology, they train surgeons in how to do, proper endometriosis surgery with care of adhesion prevention. And this has been researched, through the St. Paul VI Institute, adhesion prevention techniques, and the right way to actually remove endometriosis, which is excision. Excision is the gold standard. So you can't go in and just what we like burn over endometriosis. You can't just kind of put a little patch over it or anything like that. It has to be excised out either
Mhm.
by a CO2 laser or through cutting tools, and then properly repaired to protect the tissues and to prevent adhesions. Now, you cannot go to any OBGYN and get this done. I'm sorry. It is not going to work out for you. You have to do your research. You have to find a surgeon through NAPRO technology. You can contact the St. Paul VI Institute. You have to find someone who is specialized in endometriosis and knows that excision is the gold standard. And, this now is done through laparoscopic techniques and through Da Vinci robotic techniques so that, the incisions, the amount of kind of recovery has been minimized significantly over the last
Mhm.
20 years.
Mhm.
So that's awesome. And with a surgeon who knows how to properly treat the disease, your reoccurrence rate should be between 10 and 20%. If you go to a doctor who doesn't understand the disease and says, well, yeah, I ablated it or I burned over it and I got probably half of it, and now you have to go on birth control or this other medication to continue to suppress it, you have gone to the wrong doctor. And unfortunately, that happens to so many women. And that reoccurrence rate is, well, I mean, if you didn't remove it all, it's reoccurring because it's still there. But
Mhm.
even if you thought you removed it all, the reoccurrence rate for someone who uses just cautery or ablation to just kind of burn over the top of it is going to be somewhere between 40 and 60% at least.
Yes. Right.
So I cannot stress enough that you have to go to a surgeon who's properly
Mhm.
trained in treating the disease to get that beautiful small reoccurrence rate and pain-free cycles. I mean, the amount of women I've seen who've had proper surgery who go from terrible pain to no pain is amazing. It's absolutely incredible, and you deserve that as a woman.
Same. And I think there's this fear in women, which I totally get. You think, oh my gosh, surgery. I don't know if I really want to do that. But the number of women that I've worked with who were nervous, one was, I think, even 17 or 18. They went in to get surgery. And I know the parents were really nervous, but it was just terrible for her. Terrible, terrible, terrible. And after her surgery, it was just a couple months after, and she's a completely different young woman. She's just completely different, and a completely different relationship with her body, completely different relationship with her cycle. Surgery seems so invasive and scary and kind of like a non-option, um, which is unfortunate because in reality, I think when we think surgery, we think like, let's open you all up and do surgery here. So, Teresa, tell our listeners a little bit about what laparoscopy and excision and the invasiveness of that is, so that people kind of get a better, clear picture of that.
Yeah. So there's two kind of steps to this. For the most part, most women going in to look for endometriosis or their doctor going in to look for it, it should be called a diagnostic laparoscopy. And that is an outpatient procedure. You recover within a few days to a week max. You're home the same day. So you're not staying overnight in a hospital. There's two incisions, one through the belly button. So you won't even see that incision. And then a tiny one that goes right above the pubic bone. So the incisions are minimal. And the surgery takes an hour to an hour and a half, usually. I would say an hour and a half on average. And if done right, the doctor should be taking a lot of time. We call this near contact laparoscopy to investigate everywhere in the, abdomen and pelvis. And again, what happens is if the doctor can remove the endometriosis 100% in that surgery, 100%, then they may do that. But many times for our patients, especially, that is just the diagnosis. So you're in there and you see it, you've now diagnosed all the areas, but now we have to go back through a Da Vinci robotic procedure to do the proper excision removal and adhesion prevention techniques that are necessary. And again, I'm not a surgeon, but I know these surgeries very well. And you can even go on the St. Paul VI website and look at adhesion prevention PowerPoint presentation by Dr. Thomas Hilders to explain this, why it's so important. But the Da Vinci robotic procedure is commonly done for moderate to severe endometriosis, and it can take hours to do that surgery if done right. I mean, we've had cases go up to 10 hours.
Wow.
So that's definitely a more advanced procedure, but we're talking, again, cure for years and years and years and years, or never coming back. That is well worth it. And the complications, from the surgeries are extremely rare. And even with the 8-hour surgery, you still may go home that same day and recover over about 2 to 3 weeks. And those incisions in the Da Vinci robotic procedure are bigger, but not really that big. They're about 2 to 3 centimeters, and you have a few of them on each side, or actually just 2. But so that's just super important, again, to know that. A couple of things people wonder about is diet, Jamie. So I just want to touch on a few kind of complementary treatments that go with endometriosis. A lot of people will hear about, can you like cure endometriosis with your diet? No, you can't cure endometriosis with a diet. We don't have any research to say that. Can you make improvements in how you feel with diet? Absolutely. And is it a good idea potentially, if you've had surgery for endometriosis, to be on a anti-inflammatory diet? Yes. And anti-inflammatory diet, that's a general term. There's lots of niches in the anti-inflammatory diet world, but there are general principles that are kind of followed in that. You get rid of kind of the processed foods. You try to eat toxin-free foods or organic foods. And for the most part, you're going to get rid of gluten, because gluten is found to be inflammatory. And in many cases, people need to get rid of dairy too, although that one is kind of up and down in the air depending on the person. So processed foods, clean up the diet, clean out sugar, especially, get rid of gluten, and many people feel so much better. And the research is starting to grow on whether or not this actually prevents the reoccurrence of endometriosis, but we have limited data because it's hard to do studies on diet. It really is. There's that. I can't say enough about having a good women's health pelvic floor therapist. This is something I think people do not, investigate or get the opportunity to know about. And this is either before you've been diagnosed with endometriosis, if you have pain, this is something to investigate, but especially if you're diagnosed with endometriosis and you've had surgery, ask your doctor about a pelvic floor therapist, a woman's health certified physical therapist, because they do a tremendous job in helping to restore alignment, to restore strength to the pelvic floor muscles. And I've seen really amazing cases where that has made a huge difference in recovery. And I don't think a lot of people know about that.
So recovery from the surgery.
From surgery.
From the surgery, not
yes.
Into preventing. Okay.
Because there are some people that will still have pain post-surgery.
Sure.
And by the way, the first month after surgery, people still have pain because there's a lot of inflammation. So if you've never been told after surgery, that first month is always going to be worse. And then by the second, third month, it's so much better. But I just think that's a missing piece of the puzzle that we should, really be offering to women. And I have got some great trained women's health PTs here in my area.
Awesome, Teresa. And didn't you do presentation also through Guiding Star about endometriosis? Maybe we could link that in the notes.
Yeah, that's a great point. It actually, did a webinar on endometriosis, go through some of the, history of surgery and a lot of this information through the Guiding Star project. It's on their website under webinars, but it's hard to find on YouTube. I even sometimes struggle finding it, but so we'll link it in our description. So that's a great idea. That will kind of summarize everything too. But endometriosis, very, difficult condition. Women really need answers. This is just, we're barely touching on it. We've got 176 million worldwide. that have endometriosis. I think it's well over 5 million in the United States. I think there's starting to be more advocacy for women who have endometriosis, but there's so much more that needs to be done. If you're suffering with pain, there's nothing wrong with you. You likely have a condition that can be treated.
Yeah.
So if you're wondering, do other people experience what you're experiencing? They probably aren't. And that's not your fault, but please speak up about the pain that you're going through, and do not just think, oh, well, everybody has this.
Right.
Because that's not true. Most women don't have this type of pain. Most women have cramps when they're younger, and a couple ibuprofen takes care of them. And, that is different than being home in bed for a day or two. This is a really important thing, because pain is not okay.
Right.
And women do not need to suffer with this.
And for those of you who cannot quite get to the root of why am I not getting pregnant? Why am I not getting pregnant? It seems like I've, turned every stone. I am struggling, a huge question mark. Definitely reach out, check fertilitycare.org, find your nearest fertility care practitioner, find your nearest naprotechnology doctor. And there are protocols and standardizations that occur within this system. So it's like we all speak the same language. So even though we're talking about it now, we were trained in the same way that all these other people were trained too. So definitely, again, if you're feeling pain, or even let's say you're not feeling as intense pain, but you're just not achieving pregnancy, and there's that curiosity there, we just encourage you to look more into it. And then again, like we said earlier, we're going to post another presentation of Teresa doing a webinar for the Guiding Star Project talking about endometriosis. But for now, we hope that this information was super helpful to you. I'm sure many of you, we know from our listeners, what do we do about pain? Why am I experiencing so much pain? So hopefully this has helped answer some of those questions. And as always, if you have follow-up questions, email us at thehormonegenius@gmail.com. Follow us on social media, and be sure to share this with your friends and family. Thanks, Teresa.
Thanks, Jamie.
Bye, guys.